So I'm sure that you have all in this group have heard about the age wave, the silver tsunami that's coming. But one of the statistics that for me is most frightening in all of that is the parent support ratio. Have any of you seen this before or heard about this? So what this parent support ratio is it looks at the number of people who are going to need help from families, and those who are most likely to need help are those older adults over the age of 85, and comparing that with the ratio of those who are most often ending up in the family helping caregiver perspective, those between the ages of 50 and 64. Now in 1950, for every 100 persons who were in that caregiver category, there were 3 people over the age of 85 who would likely, therefore, needing help from family. By 2050, you go to a 1 in 3 chance, if you're in that 50 to 64 age category, of being called on to help a family member. And this is the statistic, I think, about the coming age wave, the baby boomers getting old, that for me is the most frightening as we think about how not just are there going to be huge numbers of older adults, but the next generation is so much smaller who typically provides care. And so what I'm going to talk about today is a little bit about how we can try to continue to support those families who we cannot afford to pay for the care that families provide. So again, if this projection about the ratio, parent care ratio continues, by 2030 about half of the families in the US will be caregiving, and that will increase to about 2/3 by 2050. We cannot afford to pay for the care that families provide in this country. This is from the Alzheimer's Association, and in Oregon, in 2010 it was estimated that there were 163,000 caregivers providing care to somebody who had dementia. And they were providing a total of 185 million hours of care that year. And the total value of that unpaid care, if we had to pay for that care instead, the total value of that would be $2.2 billion, that's with a B, $billion in this state alone. And we're not the largest state that's providing this care. So for me, this is really the compelling statistics that I think help me understand how important it is that we try to support families who are providing care and to recognize that they are already providing the bulk of the care to people who have Alzheimer's disease, and we need to do what we can to try and ease the burden that they experience. There has been tons and tons of research that has noted that there are many negative consequences for family members who provide care to an older relative with Alzheimer's disease or with dementia. Mental health consequences, depression, anxiety, physical health problems. Caregivers who provide care for older adults with Alzheimer's disease have higher mortality rates than caregivers to people with other illnesses like cancer or Parkinson's. It results in lifestyle changes, decreased privacy, decreased time to engage in other activities, decreased well-being, and also puts a tremendous amount of strain, not just between the caregiver and the care receiver, the person with dementia, but also between the caregiver and other family members as well. So why is it that caring for a family member is so stressful? My guess is you probably in this room all know, but I'm going to go over some of it. Part of it is because the care can be complex. As Elizabeth was saying, patients with dementia often don't have just dementia, they have other health problems as well, and so that care can be very complex. It can be physically challenging, particularly as the dementia progresses and the person needs more and more help with their activities of daily living. It can be very time consuming, and emotionally it's very difficult. One of the reasons why it's difficult is that sometimes there are mismatched expectations between what the caregiver thinks the person with dementia needs and what either that person themselves believe that they need or what other family members believe the caregiver should be doing for them. And so one of the things that can help, of course, is clear communication. and to recognize that people with dementia have a need to continue to be involved, and that the diagnosis doesn't mean that they're no longer able to do things for themselves, and that perhaps as family members we need to be willing to entertain a little bit of degree of risk in allowing them the autonomy that continues to be important to them even as the disease is progressing. Caregivers worry a lot, and the worry results in depression, anxiety, increased blood pressure. But that time that they spend worrying is often unproductive and not really helping solve any of the problems with caregiving. So one of the things that can help is to ask caregivers to set aside time for worry. A clinical trial that Pat Archbold and Barbara Stewart did working with families who were engaged in caregiving tried to help them set aside, okay, so let's just set aside a specific time each day if you'd like where you're going to engage in worrying, and then know that the rest of the time you're going to try and not do that. Some caregivers are actually able to do that and to engage in that. The other thing that can help, and this is where I think health professionals can be assistants, is if you help them envision, well, what's the worst case scenario? What are the things that you are most worried about, and how can we develop a plan to put into place if that happens? So if you're worried that your mother is going to get lost because she's still driving, let's put in a plan for what you're going to do if you think that has happened. What are all the things that you can know so that when it does happen, you're already prepared to do it? And we know that preparing people for eventualities can actually reduce the amount of stress that they have in worrying about those things. And sometimes they don't happen. And so that's the other good thing. Role conflicts. Caregivers are often balancing multiple roles. Sometimes adult children of persons with dementia are referred to as the sandwich generation because they may be caring for aging parents. They may also have grandchildren or children that they're also providing care for. They often have work, and caregiving can interfere with work in very significant ways. So one of the ways that you can help caregivers manage some of the role conflict is to help them engage in prioritizing. And one of the ways that you can do that is by asking them to project time in the future and to think, 10 years from now, when I look back at this time, where am I going to have regrets that I haven't spent my time? Am I going to regret not having gone to my kid's soccer game? Am I going to regret not having spent time with my mother? And sometimes, again, you can't make up time that when it isn't there. But sometimes it helps people get clear on a day-to-day basis about where they're going to spend their time, what their energy is going to go for, if they can think about where are they likely to have more regrets. I think most of us, when we look into the future, we rarely look back and regret that we didn't spend more time on the computer. We rarely regret that sometimes you may have regrets about not spending more time at work, but that's a lower priority, and that really it's time spent with family that most of us, when we think about what our priorities are, that's where it becomes clearer. And sometimes reframing that as what are you going to regret down the road can help families articulate that. Lifestyle interference. It's stressful because you have reduced privacy, especially if you've moved the older adult into your home. My grandmother, when she developed dementia, lived with my family for 6 months out of the year and with my mom's sister for 6 months out of the year. And when she was with us, it was a much more chaotic environment than it was. She actually, one of my brothers was very young. He was 5 years old at the time. And she shared a room with him because our house was small. And so he had less space and less privacy. She would sometimes hit him in the night, which he actually was quite understanding for a small child, was quite understanding. But it really interfered with lifestyle. There were things that my mom couldn't do with my younger siblings because of the providing for care. So one of the things that can help is if there are services that are available, and the ADRC and some of the other organizations can help families get in touch with what some of those services are. I always say call the Alzheimer's Association. That's, I think that's one of your best first stop. But I think sometimes we also have to work with family caregivers around how to help them access help from their friends and family that they may be having difficulty with. And part of this is, there's an interesting dynamic that happens. If I ask somebody for help, that can be really hard to do, either because they may think if I'm asking them for help that I'm being manipulative in some way, or it may be hard for me because I have this notion that I'm interfering or I'm causing a burden for them. And yet if somebody asks me for help, I want to do that. If I have a friend or a family member or a colleague who has a need for help, I really want them to ask me. And perhaps it would help if they asked me specifically, could you come over and just sit with my mom for a couple of hours so I can go grocery shopping? So if we can help family caregivers come up with specific asks for the ways that they can get help from their social network, I think it helps connect the desire for help that family and neighbors and friends have with the needs that the caregiver has. I think we also have to help when there are out-of-town siblings, how to help them come in and be a helpful presence. I don't know if any of you have had this experience, but oftentimes out-of-town siblings are unwelcome intrusions into what may be a difficult but delicately balanced, is that an understatement to hear you say? But a delicate balance. And the out-of-town sibling comes in and they've got ideas about what you should be doing to entertain mom, what you could be doing for yourself, how you could do her bath more efficiently. And what the sibling, what the caregiver hears is how everything I'm doing is wrong. Nothing I'm doing is enough. And so I think we have to coach out-of-town siblings and out-of-town family members, or maybe even local ones who aren't the direct care provider, how to ask, what is it that I could do that would be most helpful to you? This is the time that I have. I'm going to come for a week. What would be most helpful? I don't want to be an intrusion. I don't want to upset your apple cart, but if there's something that I can do that would be helpful to you, please tell me. I think we also have to coach them to ask the caregiver, so tell me how I should do this. How should I, do you have hints? I think that's it's a courtesy that we can give to the family caregiver so that they feel as if they are the expert, that they are empowered to say, well, this is what I've found that works, rather than being told what I'm doing is not the right way. Even if you are convinced that you know a better way to do that, this might not be the time to give that piece of advice. My mother always used to say, advice is to be given, not taken. And I've tried to encourage her to rework that to say, advice is to be asked for, not offered. But I haven't had any luck in changing her about that. Unpredictability is another difficult part of caregiving, particularly with dementia. The behaviors that you're seeing today may not be the behaviors that you see tomorrow. What worked today may not work tomorrow. And trying to get into a routine can be very difficult with somebody who has dementia. So some of the things that can help is, first of all, if you can, planning for disruption. I had a colleague who was an administrator, and one of the things she started doing very early in her career as a busy administrator was to leave a half-hour cushion in the middle of the day to absorb whatever unexpected crises came up. And that it was just this, it was crisis only, and she really protected that time. And I think if we can coach family members sometime to not be so booked in their schedule that they don't have time for mom resisting getting out the door when they have a doctor's appointment, for example. I think also it can help families sometimes if they keep a record or a diary or write down patterns that happen. When you're involved in caregiving, it's very difficult to see sometimes that there in fact is a pattern to when things happen or to when the crises come up. When, we talk a lot about people with dementia having sundowning. I'm not sure if it's that as much as it is that a syndrome, and maybe it is a really distinct syndrome, but I oftentimes think think that it may have to do with low blood sugars, with people being hungry, getting fatigued during the day. We talk about sundowning in long-term care facilities, and sometimes I think it's because when you have change of shift in the afternoon, there's suddenly a whole lot of additional bodies, noise, commotion that's happening that people with dementia sometimes, I think, pick up on. And we call it sundowning when in fact I think there may be other triggers. So looking for patterns for when those behavioral symptoms are occurring, and trying to write things down and then looking back and to see if there's a regularity or a pattern can sometimes be helpful, so that what feels like something that's unpredictable, in fact, is actually something that you can plan for and have better prediction around. Financial strains. I don't mean to be flip about this. I think, unfortunately, we have very few resources to provide to families, particularly those living in the community. You know, in Oregon, anytime the budget gets tight, Oregon Project Independence is one of the first things that's on the chopping block. It's an important program that provides important services in the community for families caring for older adults. And so I think we as a society need to make decisions about what it is we want to do. And again, I think the magnitude of the needs that are coming down the pike are really going to force the economic issue. We save a tremendous amount of money in care if we can delay nursing home placement or assisted living placement and support family caregivers. And it takes a lot less resources, fewer resources, to support that family to continue to provide care, oftentimes, not in every situation, but oftentimes, than it does to pay for the care to be provided. And I think we just need to recognize that we as a society need to do a better job of making these resources available. So that's my political soapbox. Lack of resources. It's not just money that caregivers oftentimes have a shortage of, but also time, help, and sleep. And again, thinking about what are the goals of care. You know, I love the presentation that Elizabeth did in really couching the decisions that we're making around what are the goals of care. My mother used to spend hours forcing my grandmother to go to the beauty parlor to get her hair permed, to get her hair put up in rollers, and to get it done on a weekly basis. I think because she was hanging on to something that she believed had at one time was very important to my grandmother, but as my grandmother's dementia persisted, her hair in rollers or her hair looking good, my grandmother didn't really notice. And when my mom could let go of that and realize that it was really her need to hang on to something, and instead she just let my grandmother's hair grow, she was able to braid it, and that was it. She, washed it seldom, and that was a much better situation for both my grandmother and I think my mother, that they were no longer having that conflict. And so thinking about what are the goals of care and how can we change care in ways that makes it more manageable and more doable, and so that we're letting go of some of the battles that perhaps we no longer need to fight. I think we can see that sometimes with medication. I get asked a lot, at what point in time should I stop, particularly those medications that may be being given for dementia. And, I don't know that family members are often very reluctant to stop giving those medications. But I like to talk to them about when the battle to get them to take the pill is more disruptive than any benefit you think they're getting. That's probably the time to think about stopping those medications that they likely have already, by that time they're probably minimally contributing to improvement in the brain at that point. I don't want to paint a completely negative picture about caregiving. I think it's important that we also recognize and acknowledge that for many caregivers, caring for a family member, even if they have dementia, can be very meaningful. We've done research with a number of caregivers who say that it really helps them feel as though they're paying back to a parent what they had given them. and that they're truly finding positive benefit for themselves. Again, a study that Pat Archbold and Barbara Stewart did looked at trying to help caregivers find more meaning in the caregiving that they were doing, so that creating rituals around certain care activities, so that bathing wasn't a battle, but instead became a pleasurable activity where you use scented oils that may have evoked positive memories for your loved one. Taking walks in order to get exercise, but walking to a destination like the ice cream shop around the corner instead. So helping caregivers find ways to find their caregiving more meaningful can be a way to reduce some of the negative sequelae. I think it's one of the things that is sort of certain about caregiving, particularly caregiving for persons with dementia, is that the problems that you're dealing with today are likely to change. That they're probably not going to be the problems that you're still going to be dealing with a year from now. And that can be both good news and bad news for caregivers. And I think in keeping with what Elizabeth was saying, that we need to prepare caregivers for the fact that the situation that they're in right now is not likely to be the one that they will be dealing with a long time down the road. And we have to help them prepare for that. One of the things that caregivers find most difficult, a number of studies that have been done looked at caregivers and how much stress is caused by the cognitive impairment that the older adult has, how much is caused by the disruption or the functional impairment, the inability to do activities of daily living, and how much is caused by behavioral symptoms. It's probably no surprise that it's the behavioral symptoms time and time again that are most distressing for caregivers. And I think not just for family caregivers, but for our direct care workers and paid caregivers in both in the community and in residential settings. I think it's the behavioral symptoms that are most difficult. And so what I'd like to do with the time that I have left is to talk a little bit about managing dementia-related behavioral symptoms. And what I've done here is created a framework, a sort of a decision-making tree, if you want, about thinking about behavioral symptoms. And so I think the first thing when you're encountering behavioral symptoms is, first of all, to see them as a symptom of the disease. Sometimes we call them behavior problems. Not all symptoms are problematic, and not all of the symptoms we see require intervention. And I had a caregiver who said, my husband puts jelly on his cereal. I used to correct him and it caused problems, and now I just let him do it. Why can't you put jelly on your cereal? So there are some symptoms that, because they really aren't harming anybody, that we don't need to deal with. When they are causing problems, I think we have to try and identify what are the possible underlying causes or the precipitants, those things that are increasing the likelihood that those symptoms are occurring, and what strategies can we use to manage those underlying causes or the triggers, and then how can we measure success appropriately. I think sometimes we hold a really high bar for ourselves with behavioral symptoms with dementia, and it's an impossible bar to achieve. And if we set our expectations just a little bit lower, so with my mom and the hair, for example, really what was most important is that my grandmother mostly had clean hair that stayed out of her face and didn't cause her problems. I mean, that was really success. And if my mom continued to define success as my grandmother looking very well coiffed like she did in her earlier life, that was always going to be a battle. So helping caregivers figure out what's a reasonable expectation given where this person is at with their cognition, I think is an important part of the overall management. And then figuring out when to change the approach. When what you're doing isn't working, knowing that sometimes it's going to work today and it may not work tomorrow, but the day after it may work again. So some hints around when to change. There are two different theories, opinions, if you will, about what causes the behavioral symptoms in dementia. And I'm going to go over both of them because I think each of them has something to offer in how we think about the behavioral symptoms and giving us some strategies for going forward. The first one is called the Progressively Lowered Stress Threshold, which is a mouthful to say. And then the Need-Driven Dementia-Compromised Behavior Model, also not very simple. So what the PLST model suggests is that for all of us, normal behavior is really a function of what our personal competence is and the environment in which we are acting. So if you pick me up and put me down in an environment where I have very little knowledge or skills, if I have to find my way to a place in Rome, I'm probably going to have very altered behavior because I don't have any knowledge of the language, I don't know the city. I'm likely to function very poorly in that environment. I could probably function a little bit better in London because of the language, that I could mostly speak the same language. And so I think this helps us as we think about patients with dementia. We know that they have decreased personal competence because of the cognitive impairment that they have. And so when we put them in environments that either are not stimulating or interesting enough, or in environments that are overtaxing and overstimulating for them, we're going to see some behavioral symptoms occur. We see this when a patient with dementia goes into the hospital. They may have been functioning really pretty well at home. Now we don't know whether or not they also have a delirium, so that we if a delirium is superimposed, that further decreases their personal competence. But we also are putting them in an environment that is disrupting their sleep, that doesn't have day-night variation, where there are lots of noises that may be difficult for them to interpret. And those are the patients that we also put right close to the nurse's station, where there's even more noise and never any quiet during a 24-hour period. If, however, we can either increase the personal competence by treating whatever underlying medical condition might be reducing their already reduced personal competence, or if we can either decrease the environmental demand or increase the environmental supports that are there for them, then we can help them achieve better competence. And we've seen this in some of the memory care units. We understand that for patients who wander, having a wandering path where they can wander freely is helpful to them. We put them in an environment where they can be safe, and the wandering is no longer a behavior that is as disruptive as it had been if they're in an environment where they either have dead-end hallways that they encounter, or where they feel thwarted in their wandering, where people try to prevent them from walking around. So thinking about what are the things that we can do to make the environments in which an older adult is functioning can be very helpful. One time I was talking with a family member, and she was complaining that she could never get her husband to go to bed at night. They had a living room that had a mirrored wall, and he wouldn't go to bed until the guests have left. That's a reasonable, his social skills are intact. Social skills often remain intact as the disease progresses. And so putting drapes that she could draw to cover the mirrored wall so that he thought that the people were gone was a way that by changing that environment, she was able to get her husband to go to bed at a reasonable hour, rather than trying to orient him to the fact that this is me, this is my reflection in the mirror. That didn't work and doesn't work. The other model is the need-driven model, and the opinion behind this model, or the thought behind this model, is that dementia represents a state of affairs where the individual's psychological and physical needs are often only poorly met. And if instead we can meet those underlying needs, we can do a better job of reducing the incidence of the behavioral symptoms that we see. Thomas Kitwood has done a lot of writing in this area and has helped us understand what some of the needs are of persons with dementia. And he talks about the need for attachment, that it's really a universal need that all of us have, And that when we lose our sense of security or our sense of being attached to individuals with whom we feel safe and secure, that you can see some behavioral symptoms happen. And so, sometimes we see this with people with dementia who perhaps are asking, have you seen my mother? Or I want to go home. Oftentimes, they may not be asking for their mother specifically, or they may, or a specific home. Some family members will tell stories of taking somebody to a variety, to the childhood home because, dad wanted to go home and that really wasn't still home. Instead, I think if we think of home or mother or father as being a metaphor for a sense of security or a sense of familiarity, that perhaps we can meet that need better than assuming that we have to tell them that their mother has died. Again, another example of reality orientation that doesn't work. Comfort is another basic human need, and on the list of medications that older adults have that you're thinking about getting rid of, the last one, and it should probably stay on, is if they are on a pain medication for some reason. We do a very poor job of treating pain with older adults in general, particularly older adults with dementia. And so if an older adult with dementia has a diagnosis that we typically associate as being painful, for example, arthritis, and they used to take something because they had arthritis pain, chances are just because their dementia has progressed, they are still having arthritis pain. And so we need to continue to treat pain. Comfort also isn't just about treating pain, but soothing and offering comfort to someone. There's a video that some of my students sent to me that Naomi File has done. If any of you have seen that, where she's talking to this older woman with dementia, very advanced stage dementia. She's described as somebody who's no longer verbal. And Naomi rubs her cheeks in this very gentle, soothing way and starts singing some hymns to her, and this woman starts singing along with her. It's really quite remarkable to see this happen. And so the soothing comfort is also something, I've often wondered whether or not we should swaddle older adults with dementia because that snug, comforting feeling. I haven't seen any research on it. I don't know if anyone is familiar with any, but I sometimes think that they need to feel comforted in ways that we're not doing a good job of. Identity is also an important basic need. And when an older adult with dementia no longer recognizes their image in a mirror, they're sometimes frightened by that image, that's I think a really deep loss. And to try and help them connect with who they are and who they have been can be really important. And so understanding what some of their early history has been is a way to help them connect with that. Sometimes the reminiscence therapies, sometimes smell therapies, sometimes music. That's music that, there's an iPod project that's going on, if any of you have heard about it, where people with dementia are being given iPods that have music that they had enjoyed in their life, particularly earlier in their life, and they seem to be tolerating it very well and seem to be getting some pleasure out of it. So trying to connect with who that person has been. A sense of inclusion is also really important, and I think that's one of the lessons that we're learning through some of the cultural change work that's going on, is that we really need to find ways to allow people with dementia to continue to feel as though they're giving back, they're participating, that they're included. And folding washcloths may not be the best way to help somebody feel included. That may help for some, give them a sense that they're doing something. But I think we need to be more creative in thinking about how an older adult with dementia can feel as if they're a part. I visited an assisted living facility in town that, and visiting, it was required that I attend a meal while I was there. If I was going to visit, I needed to see what being there during a meal was. And one of the gentlemen who was there was in a wheelchair. He was on a ventilator. He wasn't verbal. He couldn't really participate, and yet when everyone in that unit sat down for the meal, he was brought to the table and placed there as well. And the other residents took it upon themselves to tell me who he was and introduced me to him and included him in the conversation. Again, I don't know about his background, how much he may have been able to follow cognitively or not, but it was a wonderful example of including somebody in, he had tube feedings. He was not going to partake of the meal that everyone was eating, but I think a really important way that he was included in all of the meals. And I really could tell by the way that they knew him that this wasn't something that they were doing just because I was visiting. And then occupation or meaningful activity is another important need that all of us have, and it doesn't necessarily go away when if we develop dementia. And so figuring out ways to connect with people, to have opportunities to engage in what they believe to be a meaningful activity. And again, that may be something where we have to be willing to take on a little bit of risk. I don't know if any of you have seen the video about the older adult choir. I'm going to blank on it. No, it's not that one. It's Young at Heart. Young at Heart. And some of the stories of those older individuals who, for the one guy who, singing in that choir was so important, even when he was dying, he showed up at practice because being at practice was what gave his life meaning. And I think there again, we need to understand what are the personal goals of this person with dementia and how can we continue to do that, even if there are risks involved. I mean, he really compromised his health by showing up at practice. And yet that was so important. And he ended up dying before the concert was there, but everyone in that choir knew, and watching the video, you knew that him having been at that last rehearsal was so important to him. So I think we need to figure out ways of continuing to include older adults with dementia in meaningful ways. So what are some of the causes, or how can we address some of the underlying causes of some of the behavioral symptoms we see? Again, pain. I think we have to think pain early and often. And sometimes what we describe as aggressive behavior, being hit, pinched, scratched during care activities, may actually be self-protective behavior. And if we saw it as self-protection rather than as aggression, how would we respond differently to that? Unmet needs like hunger, thirst, fatigue, constipation, low blood sugar. I think we have to be thinking about those things, that they may be causing some of the symptoms. Unmet emotional needs, anxiety, fear, loneliness, new or misinterpreted stimuli in the environment. It may be a pattern behavior from previous occupation. There's some research that suggests that individuals who use exercise to manage stress may be those who wander when they develop dementia. And so recognizing that there may be an underlying meaning to that behavior. Might be adverse reaction to a medication, particularly if that medication has an anticholinergic side effect. And it may be an illness that has an atypical presentation where the symptoms aren't obvious to us because the person can't communicate what they're experiencing. So interventions that target underlying causes or needs need to manage pain effectively. I know I keep saying this over and over again, but one of the things I like to ask my students is, what are the analgesic properties of Haldol? Yeah, zero. And so if we're treating some of those symptoms with an antipsychotic agent and what's causing it is pain, we're really just masking those symptoms and we're not really treating the pain very effectively. So we have to address the unmet physical needs. I'm a big believer in ice cream as both a distractor and as a soothing kind of intervention to use. Engagement in social activities or meaningful work, and assessing and treating underlying illnesses. Some of the principles of behavior symptom management that I hope you'll keep in mind. do no longer use reality orientation, please. You know, families come to this on their own. My students, you know, it's like it's programmed in us that we do reality orientation. You know, Lily Tomlin said that reality is nothing more than a collective hunch. And you know, I've had students on a dementia care unit, and Margie, one of the women there, after dinner, we were there on the evening shift, she would gather up some of the other little ladies, and they would go for a hike because she believed that she was at camp. If you can reframe being on a dementia care unit as being at camp, you can hike all you want. You know, that is fine for me. Align with the resistance. Sometimes when patients with dementia resist, what we do is we try to pull harder or push harder. And that's, you know, that's going to be a power struggle, and somebody's going to get hit, and it's probably going to be us. Instead, and it's not just physical resistance, there's also emotional or verbal resistance. If you've seen the Bathing Without a Battle video, in one of the scenes, the woman is saying, you know, I don't want a bath. You don't have to give me a bath. You don't have to give me a shower. And the aides feel compelled. Yes, I have to give you a shower. I have to give you a shower. Well, that just escalates into the aide getting bit and the person on the shower chair going backwards and hitting her head in the shower. So instead, you know, when a person resists, we have to respect that resistance and figure out, is there a way that we can align with them? So another on the dementia care unit, one of the ladies after dinner every evening, she would say, you know, first she was embarrassed because she didn't have money with her to pay for her meal. And I would say the same thing every evening. I would say, that's okay, you know, everyone's meal is taken care of tonight. We're doing that for everybody. Because if you say it's just for her, that often isn't okay. So I'd say, you know, we're taking care of everyone's meal tonight. And then she would say, if you call me a cab, I'd be happy to go home now. And so what I would say to her every night was, oh, we were kind of thinking that you were going to stay with us this evening. And she would say, oh, I said, we have a room all ready for you. And so we would walk down to her room, and she would go into her room, and she would often look at the things and say, you know, the things that were hers in the room, and she'd say, this'll do. I didn't have to get her to understand that she lived there and would be staying here every night. She only had to stay tonight, and then we needed to do that again the next night. And so sometimes I think we, you know, we can, if we truncate the, you know, the time around it, all I have to do is buy time and get through this. That's, again, it's sort of defining success differently. She doesn't have to know that she lives here in order for her to stay here tonight. And that's really what I want. And so, not align with the resistance. I didn't tell her, oh, you live here now, we can't call you a cab, you don't have a home, none of that, you know, which would have escalated her resistance, because she would have insisted that she did have a home, and she could tell me, if I called her a cab, that she would get there. I think also we have to, when we can, take advantage of the cognitive impairment and the distractibility and the short-term memory impairment that is there. I had a student who was working with a woman, Tanya, and shortly into the shift, Tanya kicked her out of the room and slammed the door very dramatically and said, and never come back. And the student was like, you know, what am I going to do? I said, we're just going to wait. We're going to let Tanya cool down a bit, and then you're going to go back in as if you've never met her before. And you're going to introduce yourself, and you're going to tell her that you're a student, because Tanya used to be a phys ed teacher, and she loved working with students. And I said, and you're not going to mention anything about having been kicked out of the room, having met her before. And she went in, reintroduced herself, and Tanya was very happy to take this student under her wing and help her get through the evening. So, you know, sometimes we bring baggage into interactions with people with dementia that we don't need to. And so, again, recognize that your mood is contagious. So if that student had gone back in sort of hesitant and tentative, my guess is that Tanya would have picked up on that and thought there's a reason why she's being hesitant and tentative, and I should perhaps be hesitant back. So understand that if we go into the room expecting a battle, we're likely going to get that. Again, all behavior has meaning, and I think it's our ability to try and help families and to help other care workers understand what is the meaning of that behavior. Simplified communication. Somebody who cannot do a 3-step command on the mini mental status exam, you can't expect them to, I want you to go in there and get dressed and, brush your teeth. We have to break down the instructions that we're giving and give positively worded directions. Attend to the emotion as well as to the content. Sometimes we interpret literally what patients with dementia say, when in fact I'm not sure they're being literal in what they're saying. Or at least if I assume that it's literal, it's going to be difficult. And that I want to go to work, I got to go home. My children are waiting. I need to go home and cook dinner. If we assume that is really what they want to do, then we're going to engage in conflict with them. But instead, if we see that as an indication of the underlying need for occupation, for a sense of familiarity, for a sense of inclusion, then I think it gives us different ways to interact. Address one problem at a time. And and set clear goals about what is going to constitute success. When we're trying to manage a whole assortment of behavioral symptoms at once, it gets too confusing, and we create unrealistic expectations about what we can really achieve. Setting reasonable, attainable goals. I interviewed a caregiver one time who was caring for her father who had dementia, her aunt who had dementia, and her mother who was cognitively intact but physically had mobility problems. And she was an amazing woman. And she told me about a time when her mother went to stay with one of her sisters to give her a break. And every day, multiple times a day, her father would ask her, where is she at? Where'd she go? Where's your mother? And the caregiver said, okay, I'm going to tell you one more time, and I don't want you to ask me the rest of the day. And he said, got it. And she said, he only asked me about 7 more times that day. She didn't really expect that he wouldn't ask her again. That would have been an expectation too high. Reestablish rapport. I think oftentimes, particularly in caregiving activities in residential settings, we go in, the person with dementia may greet us because their social skills are intact. We think we've told them that we're going to get them dressed or going to help them with their bath right now, and we start to pull down the covers and we get whacked. Or we go in there and we realize I forgot a washcloth, I go back out, I come back in, I assume they remember me because they greet me familiarly. I think we have to continue to establish rapport with the person when we're engaging in care activities. And so, I'm going to be helping you with your bath. Is it okay if I help you with your bath? We're still bathing, so that you're walking them through that. Distraction, again, I think ice cream is a great distraction. Going along, if a person is confused and they think they're at camp, I never correct them. I go along with that as long as it's not hurting somebody. And guiding or cueing, I think, is the other another strategy that can be used. So rather than giving somebody directions, if we can do that in a more indirect. Again, a caregiver told me one time that her husband's hygiene was starting to decline. And when she would tell him, honey, I think you need a shower, he would get very mad. I'm an adult, I can do this myself, thank you very much. So what she started to do was she'd lay out his clean clothes. She'd go take her shower, come out with the towel around her head, robe on. She'd say, I'm sorry I took longer in the shower than I intended to. I know you're waiting. It's free now. It's all yours. He wouldn't always pick up on that cue, but oftentimes he would think, okay, I'm going to continue to go. I see I'm getting the high sign that I'm running out of time. So one of the things I wanted to just briefly say is some warning signs for when we need to think about helping family members do something different. If the relative's condition continues to worsen despite our best efforts, the behavioral symptoms continue to increase, we need to do something different. No matter what you do, you feel like it isn't enough. We need to probably intervene with those. If the caregiver feels as if they're the only one in the world experiencing this and that they never have time or a place to be alone, and that's important to them. If caregiving is significantly interfering with work, if the caregiver feels that they're being selfish because they're thinking of themselves, or their coping methods become destructive to either the person with dementia or themselves, and there are no more happy times, I think these are warning signals that as health professionals we need to pay attention to. And I think we have to give caregivers an important piece of advice, that they must always put their own oxygen mask on first before helping others, and that if they're not engaging in self-care, that's a big warning sign, and we have to help them learn how to do that. So I'm out of time, so thank you very much.